talking about this important aspect of FFR. My topic is physiological indices in unstable angina and non-ST elevation MI. All of us know there's incontrovertible evidence that FFR is very useful as far as stable coronary artery disease is concerned. If you want to determine whether you need to intervene on an intermediate lesion in stable coronary artery disease, FFR is the modality you need to take recourse to before you're planning intervention. Also, FFR is very useful in guiding PCI in patients with multivessel disease. All of us know the 5-year outcomes of the DEFER trial, which showed that the event-free survival was greater in patients whom FFR was used, and an FFR value of more than 7.75 was a marker of preventing intervention and as well as preventing recurrent events. Now, what about the role of FFR in infarct-related artery in a ST elevation myocardial infarction? As of now, there is no role for FFR in an infarct-related artery. I'll tell you the reasons why this is so. Infarct-related artery, there is a gross constriction of the microcirculation downstream because of distal embolization, and also a lot of vasoconstrictors are released, which causes vasoconstriction downstream, and the basic premise on which FFR works is you need to have maximum vasodilation, particularly if you're using adenosine to vasodilate the distal coronary bed. So there's a decreased coronary flow reserve after a myocardial infarction, which involves both the culprit and the non-culprit vessels also. There's post-occlusive hyperemia, there's myocardial necrosis, there's hemorrhagic microvascular injury, and compensatory hyperkinesis in the distal myocardium, as well as neurohormonal mechanisms. All these together contribute to microvascular dysfunction and inadequate vasodilatory response to adenosine. Again, if you use FFR in the culprit vessel in acute coronary syndrome, you have microvascular damage and stunning, which can further vitiate the microcirculation downstream and prevent vasodilatation as a response to adenosine. As of now, in stable ischemic heart disease, both for culprit and non-culprit vessels, you can use FFR in decision making. For a ST elevation MI, for non-culprit vessels, you can also use FFR, and non-ST elevation MI also, you can use FFR in the non-culprit vessels for decision making. This is an example of a patient who had a discrete stenosis of a vessel, a 75% stenosis, and this patient already had infarcted in that vessel. There was a scar, there was microcirculation was clogged with debris, and the FFR value at that point of time was 0.84. Subsequently, over a period of time, as the flow improved, as the microcirculation improved, as the embolus was removed, the myocardium, the FFR value was 0.5 for the same degree of stenosis. This goes on to say that it's fallacious in measuring FFR in an acute situation in the culprit vessel, and all of us need to take prior attention to that when you're planning FFR strategies. There's another example of a patient who had severe LV dysfunction, was planned for high-risk PCI on the circumflex. It looked as angiographically to be significant. The patient had LV dysfunction. The end-diastolic pressures were 25 millimeters mercury. The patient was put on an Impella as an assist during a high-risk PCI. And initially, the FFR reading at that particular vessel was 0.83. Subsequently, after the Impella started working, the end-diastolic pressures came down to a 15, and the FFR value, repeat FFR, showed a value of 0.65. So this goes on to say that apart from microcirculatory disturbances, hemodynamics also play a role in determining whether the FFR value is truly a correct FFR value or is falsely elevated. Then what about non-culprit vessels in ST elevation MI or non-ST elevation MI? This is a study which compared FFR in the acute phase and the follow-up. A patient who had recovered from the myocardial infarction, the non-culprit vessel, the FFR values were same in the acute phase and the follow-up phase. So what about physiological assessment in ST elevation MI, particularly in the non-culprit vessels? There are two important trials called the Dynamic 3 Primulity trial and the Compare Acute trial. These trials compared target culprit vessel angioplasty versus FFR-guided PCI in non-culprit vessels, and they compared the outcomes of target vessel versus complete revascularization FFR-guided. And this is a flow chart of the dynamic preliminary trial program, 300 patients in both the groups, FFR-guided and the infarct-related artery PCI alone. So was there any difference in the mortality? No, there was no difference in mortality, but there's clearly a reduction in ischemia-driven revascularization in the complete revascularization done by FFR-guided. Again, both the dynamic 3 probability trial and the compare acute trial showed a benefit of FFR-guided complete revascularization in the non-culprit vessel also compared to infarct-related artery PCI alone in both these trials, although they were done in a staged manner in the probability trial and concurrently in the compare acute trial. What about physiological assessment in the non-culprit vessels in a non-ST elevation MI or unstable angina? There are a lot of trials which looked at that. I'm going to talk about 2 trials, the famous Nstemi trial and a sub-study of the FAME trial which looked at around 300 patients with acute coronary syndrome. This is the famous flowchart of the famous Nstemi trial, around 350 patients, 170 in the FFR directed arm and the 170 in the angio-guided arm. Previously, patient had to have an angiogram and to have a more than 30% stenosis in the non-culprit vessels to be randomized in this trial. So one arm, they used FFR to guide revascularization. Other arm, they used angiographic guidance. And what did they find? The primary outcome was what percentage of patients went on medical therapy after FFR guidance. And they found that after FFR guidance, 22% went on to have medical therapy compared to 13% in the angiographic guided arm. The secondary endpoints were MACE at 1 year, and they found there's not much of a difference in FFR guided PCI compared to angiographic guided PCI alone. And this is, again, famous non-STEMI trial, and the FAME sub-study also showed there was no difference in all-cause death, MACE, and target vessel revascularization in the FFR-guided arm compared to the angiographic-guided arm. Now, this is an algorithm which came out very early in 2017. After these trials came out, they compared in the unstable angina patient, the culprit vessel FFR was not recommended, non-culprit vessel FFR was recommended, and if FFR was less than 0.8, patient had a PCI, FFR more than 0.8, patient was on optimal medical therapy. Now, what about patients? You have a patient who comes with a unstable angina ACS, you did an angiogram, you found there was a culprit vessel, had a critical stenosis, you addressed that with an angioplasty, and you found the non-culprit vessels, you did an FFR, and found that the FFR was more than 0.75, and those patients would be kept on medical management. What happens to these patients over a follow-up? So all of us know that there's higher risk of MACE, particularly in patients who have an ACS before. Recurrent adverse events are more common in patients who have previously been hospitalized with an acute coronary syndrome. So non-culprit vessels in ACS patients, the reason is that non-culprit vessels have more of a vulnerable plaque, and this tends to rupture. There's one concept that if you address this vulnerable plaques with an intervention by stenting, you're going to passivate the plaque and reduce the risk of recurrent events. Again, sometimes there's an ambiguity in the diagnosis of the culprit vessel. It may not be very easy to say which is the culprit vessel when a patient presents acute coronary syndrome, and that can have a bearing on recurrent events later on. Again, there's a lower diagnostic yield of FFR and ACS because of hemodynamic changes. Now, this is a trial which was published way back in 2016 by Abdul Hakim and group. What did they look at? They looked at patients who were deferred, a patient who presented with ACS, and after doing an FFR in the non-culprit vessels, they were kept on medical management, and they looked at the outcome of these patients at the end of a year and a half. What did they find? They compared this group of patients with patients who had presented with stable coronary artery disease. They found that deferring PCI on the basis of non-ischemic FFR in patients with the initial presentation of acute coronary syndrome is associated with significantly worse outcomes than patients with stable ischemic heart disease. So caution is warranted in using FFR values derived from patients with acute coronary syndromes for clinical decision making when you're using FFR. This is what they showed in patients who had non-ST elevation MI compared to patients who had stable ischemic heart disease. The survival probability was far worse in patients who had non-ST elevation MI and unstable angina. And they found that in this particular trial, they used FFR cutoff of 0.75. They found in this trial that FFR cutoff of 0.84 was more as a better predictor of recurrent MACE or target vessel revascularization at 1 year compared to an FFR value of 0.75 or 0.8. This is the Korean large registry from Korea called the IRIS FFR registry. Again, looked at around 11,400 coronary stenosis in around 8,000 patients. The two arms, 1,600 patients had acute coronary syndrome. And what did they find? That in patients who had deferred revascularization, in patients who presented with acute coronary syndrome, the use of FFR was, if you are kind of deferring revascularization based on a FFR value, the outcomes were not as good as patients with stable ischemic heart disease. Again, there's another study which was a composite of multiple studies from the R3F, post-it, IRIS FFR, DEFINE, FLAIR, and SWEETHEART. It was a composite of all patients in this group, and they found that recurrent coronary patients who were deferred or kept on medical management based on FFR value in the non-culprit vessel, they found that the MACE rates or patients with recurrent need for revascularization was significantly higher in patients who present with acute coronary syndrome compared to patients who present with stable ischemic heart disease. This is the graph which shows that patients with acute coronary syndrome, the MACE was significantly higher than patients who presented with stable angina pectoris. Again, there's a Korean registry. We looked at the same outcomes, and again, the findings were more or less the same, that the MACE events were significantly higher in patients who presented with acute coronary syndrome compared to patients with stable coronary artery disease. And again, the FFR, in different values of FFR, again, the MACE rates were higher in the comparing patients with stable coronary artery disease and acute coronary syndrome. Again, the meta-analysis again confirmed the fact that FFR value in a non-culprit vessel in ACS setting may be fallacious, may not be a good indicator of keeping patients on medical management as far as acute coronary syndromes were concerned. So I want to conclude by saying that in patients who are present with ACS, FFR of the culprit vessel is not indicated, and conflicting evidence regarding the utility of FFR of the non-culprit vessels in acute coronary syndrome. Deferral of revascularization based on FFR value of more than 0.8 is associated with a higher rate of MACE on follow-up in acute coronary syndrome patients. If you combine physiology with imaging, it probably would give you the best result in selecting patients with intermediate stenosis for revascularization. I want to thank each one of you for your patient hearing.